Sarah Lavonne, and I'm so glad you're here. Here at Bundlebirth, we believe that your life has the potential to make a deep, meaningful impact on the world around you. You, as a nurse, have the ability to add value to every person and patient you touch. We want to inspire you with the resources, education, and stories to support you to live your absolute best life, both in and outside of work. But don't expect perfection over here. We're just here to have some conversations about anything birth, work, and life, trying to add some happy to your hour as we all grow together. By nurses, for nurses, this is Happy Hour with Bundlebirth Nurses. When I started into nursing, I knew I wanted to do labor and delivery, but I also had an interest in addiction medicine and sexual trauma as a specialty and something that I wanted to learn about and be a part of. And it's not something that I have gotten into yet. Other than I did do the When Survivors Give Birth training with Penny Simkin and Phyllis Claus, and that was before Penny Simkin passed away. And so I got to learn from the two of them and have this whole conversation surrounding sexual trauma in particular amongst the population of pregnant people and how that affects our job. And so this has always been an area of interest for me. I actually started putting together a training for nurses after becoming an educator through them. And then life took off, and this was amidst Bundlebirth. This was only a few years ago. And it just hasn't come back around quite yet, except for today, we are going to have that conversation with Morgan, who is a SANE nurse, and talk about SANE nursing, forensic nursing, what we can do to support this patient population wherever the conversation goes, with a greater look on bringing awareness to the fact that these are some hard things. If you haven't listened to episode 1 and 2 with Morgan on near fatal strangulation in our pregnant populations, please go back and listen to those 2 episodes, because I'm sure we are going to reference some information that was spoken to in the last couple of episodes, because these 2 issues, from what I'm learning, are closely related / tied, and it's hard to talk about one without talking about the other. And so today, if we are going to, again, this is my alert to all of us that the topics that are going to be talked about in this episode are mature topics. And so if there are young ears within earshot of this episode, you probably want to put headphones on. And then my ask is just to be mindful of yourself, that we know that especially we will be talking about sexual abuse, sexual assault, and trauma in this episode. And so this is your note to just pause in yourself and say, does this feel like something that I can go into today, that I can listen about? And if it's not, just move on. And you can come back or not, but that we would all just be mindful of our nervous systems. And if there are moments during this episode where you're feeling like too much, that the best thing you can do for yourself is to pause the episode, go do some walking, some bilateral stimulation, some grounding techniques, and come back if and when you're ready. And if not, that's okay as well. And so that's my sort of heads up for this episode. But I want to talk about all the things. And offline, we were saying that some of these topics, certain people are just not ready for. They don't want to hear about. That was interesting to me, because that is not what we're about here at Bundlebirth. And so we're going to talk about it uncensored, if possible, today in wherever that goes. So welcome back, Morgan. Thank you for being here and lending your experience and your expertise back to this audience. And so I want to start with just talk to me about what SANE nursing is / forensic nursing at its core. What does it look like? What's the certification? Because I'm not going to lie, I did look into it a couple days ago and was like, oh wait, this is like a thing. I can't just go to a day training. That was my stupid brain. I still might, but what does it take, and what does it mean?
So SANE stands for Sexual Assault Nurse Examiner. These are specifically the forensic nurses that are specializing in doing what we call the rape kit. Okay, so we are there to help someone after they've experienced a sexual assault. But forensic nursing is so much more than that, because as a forensic nurse, I specialize in the field that intersects with healthcare and the legal system. And I'm there to provide compassionate and comprehensive care for a person who's experienced violence, abuse, neglect, rape, any of these things, near fatal strangulation. It started out where I thought I was just going to help women who'd experienced rape. And then I learned, nope, no, you don't. It's men and women. And I don't do pediatrics, but there is a whole another subsection of pediatrics. But when you start doing that, then you realize it's not just one thing. These people experience violence, they experience near fatal strangulation. It could be neglect or abuse at home. It could be substance abuse. It's so much more. So to just say that I'm a SANE and I identify as a SANE, but now as a community, we're starting to say more. No, I'm a forensic nurse with a
Mm,
subset specialty in sexual assault.
mm,
There's training. So, because the laws are different in different states, there's some laws that are pretty universal, right? Like they match up very closely in all the states. But you can take sexual assault training, and the Academy of Forensic Nurses is where I would send you for this, or where I suggest going. The other thing is you can look in your state. Sometimes states have a particular need and they offer free training.
mm,
So I was actually trained for free here in the state of Georgia because we needed sexual assault nurses. So for us, it was our Criminal Justice Coordinating Council. They actually have a SANE coordinator for the whole state. And that's how I got trained. Now, there are certifications. Again, the Academy of Forensic Nursing is where you would go. And after you've done some training and done some time, you can actually sit for one of these. And so their forensic nurse generalist is usually like the first step. And then they have like these more specific ones that are, for example, the strangulation one. They have one for, for SANE nurses that specialize in sexual violence. But that is where you would go. It used to be there was the International Association of Forensic Nurses, or IAFN, but that got dissolved and became part of the Emergency Nurse Association. And I'm
mm,
waiting to see if they're going to put out the SANE certification again, because that's kind of where that SANE certification was owned. So
mm.
now, sexual violence forensic nurse certification is kind of the new SANE, if you will.
Okay. Sexual violence forensic nurse certification. When you say sexual violence, and specifically for the sane side of things, for when
Hmm.
discussing rape,
Hmm.
what have you found to be, and what do we know as some of the misconceptions about what rape is? Because I think society wise, a lot of times we think it's like somebody, going on a run in the fields and somebody pulls you into a bush. What
Oh,
is,
Lake and Riley. Do you
yeah.
remember her case? Yeah, the
Mm-hmm.
nurse. Yep.
Yeah. So
Um,
what is considered rape?
so there's the legal definition, which varies just a little bit, but it's essentially when someone who didn't want to have sex or did not consent to have sex and they have sex forced upon them. Right now, you can have other types of like sexual assault, sexual battery, and that's when you get into the touching and the different other sexual acts. But the main thing is that it's non consensual. Okay. So you have this being forced upon you. And then there's other different forms of sexual violence. And then all of these things, get listed as different crimes, and how they're defined within your jurisdiction. They're not the reason I say it like that is the definition, if someone for male to female, right? If a man puts his penis in a vagina and it is unwanted and whether you said no or not, but it was unwanted. You did not consent. That is rape. And then, based on the definitions, if he were to do something else, touching genitals, touching, putting things in your mouth, things like that, putting things in your anus, those get different definitions legally.
So can we talk some statistics here? Because depending
Hmm.
on your life experience, depending on like where you're at, we all lived different lives. When we say rape, that feels like, ooh, like a big one. And
It is.
I think it's easy to picture what that looks like and say like, well, it wasn't me, and or maybe it was. And so how prevalent is this day and age as far as what we know? And
Hmm.
therefore, I think we also are starting to think through the patient lens that like of the number of patients that we see, this percentage will have experienced some form of sexual violence, rape, assault,
Yeah.
etc.
The statistics say nearly every minute someone in the United States is sexually assaulted. Okay. And then every 9 minutes that someone is a child. And if you were
Ooh,
listening to one of the previous episodes, we talked about one in every 4 women at some point experiences some form of intimate partner violence in their lifetime, right? But 1 in 6 women in the US has experienced attempted or completed rape in her lifetime.
I actually think that's too low.
I would agree. I would
And
agree.
it's I and but that's like unreported, and I think,
Because
to be honest, I
it's one
wasn't.
in 33 men, and we know it's more. We know it's
Oh, for
more.
sure. Yeah.
But even then, the fact that we have 1 in 33 reporting, and about 3% of men in the US have experienced either attempted or completed rape. And that's a lot,
Yeah.
but we say that the majority of our rape victims are female, but I think I do believe that, but I know a lot of it has to do with reporting too.
Sure.
I think men are definitely underreported, and our LGBTQIA plus are 100% underreported.
Mhm. Mhm.
Mhm.
So for all of us to know that like these stats are underreported, that's a safe assumption to say like,
Yes.
1 in 6 is underreported. And I think part of that to me goes alongside the fact that I think society-wise, we are
Hmm.
not very educated on what rape is. And
Yeah.
we also aren't very compassionate about consent. That's I have a lot to say about that at another time. But for instance, literally last night, this is wild. I had a conversation with a friend whom I hadn't seen in goodness like a year, and she is younger than me. She's living her best life, and she disclosed that, and it came out, and the moment she started talking about it, I was like, oh, I know where this is going. And she said that she went to someone's house, and well, I went to their house, and I should have known better, and I this and that, and then it, very quickly it turned into something where I just laid there and I just sort of I didn't say no explicitly, but I also slightly resisted with my body language, and I didn't participate back, and it felt bad. And as she's telling me, she's getting teary-eyed, and and I just listened, and she said, so it felt like it felt bad. It didn't feel right. And I said, did it feel like rape? And she like looked at me with tears in her eyes and said, yeah, that's what it felt like. And I said, well, that's what it was. And this was literally last night. And I didn't even think about the fact that I was having this conversation today. But I think that story is a representation of, because I have a lot of understanding of this, I've done a lot of work, and I will just say in this episode, this is all I'm going to go into, but I am also a survivor of rape myself. And so, I have a level of compassion for these scenarios and being able to call what it is, what it is. And in her case, well, but I didn't say no. But I didn't say no. And the amount of shame that women I'm going to speak to women because I'm a woman and that's who I talk to about this. That women feel about well, but, and the conversation that was had was, I said, she's like, well, but I'm going to own that and listed off all these things. And I said, you could lay there with your legs open, wanting it, and then he approach you and you decide that, nope, actually, I'm not okay with this. You should be able to say no, and it should be a non negotiable. And if you have lived in the world and experienced, I'm going to say much, you know that that just is not the reality of our day. And so when we level set for this episode, what I want to bring is that rape is rape, whether you say
Mhm.
no or not. And the goal is that you decide that it's what you want. And if you feel like, and in this case, she had a hard time calling it what it was, but she said that's so validating when we actually had that conversation.
It's a
Um,
scary word to say.
yeah, and it has, yeah,
It's just
yes,
there's a reason you can't say it on social media without getting your videos banned, or we have to, use symbols and things because this is a conversation that's, I don't, I don't want to say society doesn't want to have it, but it is definitely one that is not welcome.
mm-hmm,
This is taboo.
mm-hmm,
She had a very normal response, and when you share with these people, the one thing that whether they say no or not, it's a normal response. The five trauma responses, we always talk about fight or flight, right? But there's, freeze and fawn and flop.
mm-hmm,
And we don't talk about that, right? And we don't, there's so many more responses to trauma, and they're just laying there, they're just flopping over or freezing, the inability to form the words to say no.
yeah,
There's a great YouTube video. I think every teenager, every person that is before they start having sex should have to watch it. And it's about consent and a cup of tea. And it talks about, like giving someone like a hot tea, like a cup of tea,
mm-hmm,
and what consent is. And one of the parts of the video is like, if your friend has passed out and they are passed out, you would not pour tea down their throat. You would not make them have tea. They did not consent to the tea, you know?
mm,
But it goes through all the layers of what is consent and how, and of course, if your friend is passed out, you would never pour tea down their throat, but you really
right,
want them to have a cup of tea. They might have asked for a cup of tea last week, but they don't want tea this time. And that's okay. They're allowed to say no, thank you to your tea this time. You do not just ask once. But it puts it in a very real way that people can understand, right? Because I
yeah,
wouldn't pour hot tea on you.
yeah.
And now you take that same principle and you apply it to sex or sexual acts, touching, bodily autonomy.
I love that. And also, like, for all of us, again, level setting is like consent is consent. And we talk a lot about consent at Fundelberg Nurses for like a shared decision making model at the bedside and
Yeah.
offering control. And it's no different in a sexual situation as well.
The other thing, too, is remember, you can be in the act and you can say, okay, I'm done. No. Like now, like you can withdraw consent. One of the things that we deal with a lot, and this is confusing, this is really confusing for women, and it makes it really hard for them to report. I consented to protected sex. I consented to this. I did not consent for him to remove the condom and go for round two.
Mm-hmm.
And now they're scared to report because they're like, but I did consent to this, but I didn't consent to this.
Yeah.
Like, is this still rape? Like, it's very confusing. And
Mm-hmm.
that is a very difficult one to for legal reasons and things. And the legal system is not nice to rape survivors that seek justice. It's a very hard process. It is not. And I want justice for all of my patients if that's what they want, but I approach sexual assault nursing like I do labor and delivery nursing, maximum self determination. I'm going to give you all the facts and all the information, and you're going to tell me what you want to do. And then I'm going to support you in the best way possible in what you want to do. So I don't ever shame them if they don't want to report to police. So in my world, working at a sexual assault center, and this could be different in other states, so please make sure you check the laws and things in your state. If they come to us at the sexual assault center, I am not mandatory required to report their sexual assault to the police. Now, if you go to the emergency room or something like that, those are mandatory reporters. It is a violent crime. So what would happen is the police would come and say, hey, do you want to report this? And the victim does have the right to say, no, thank you. I'm not, but I don't have to do that step if they come into the sexual assault center. So they are allowed to come and get help, get STI prophylaxis. We can also take the forensic kit and all the things. And it actually will buy them a little bit of time to think about if they want to report, let them settle a little bit. But that in and of itself has its own implications.
I was thinking back to when I was a brand new nurse. I'd have these patients who would just not progress. No matter what I tried, they were stuck. I finally would go on break, and that one experienced nurse, you know which one it is, took over for my break. And by the time I came back, the patient was complete, which is amazing, yes. And I'm so grateful for them. And it was also so frustrating to feel that helpless, to not know what to do, and then ask, what did you do? And they actually can't tell you. If you know me at all, you know that I get obsessed and cannot stop until I find all the answers, and this one got my brain going. I wanted to figure out what the heck so many of our experienced nurses were doing, and more importantly, to finally understand the body in a way that we are never taught. I wondered if there were things I was doing that could either help or hinder the labor process, and by the way, I learned there is. I wanted to equip myself with tools I could use with my hands tied at the bedside, well, both as an L&D nurse, but especially now when I'm attending births as a birth coach and my hands are tied. I'm not able to titrate the pit, I'm not able to call the doc for interventions, and I'm relying fully on the physiology of the body to help labor work. And after reading hundreds, if not thousands of resources out there and putting in thousands of hours of work, I figured it out. And I want to give you that too. If you've ever felt helpless, hopeless, or alone in your practice, you are not the only one. More than 7,000 nurses have now taken our physiologic birth class, and they describe feeling energized, empowered, and equipped for their very next shift. They walk away with practical, repeatable tools they can use with every patient. Not a one-size-fits-all prescription approach, but the ability to critically think your way through any birth scenario. A way to look at the body and know exactly where to start. You can activate physiology and optimize the systems that actually make labor work. Together, we can change the game in obstetrics. So if you're ready to feel confident instead of stuck, equipped instead of overwhelmed, and connected to a community that is committed to excellence, knowing that you're not alone, join me at our next physiologic birth class. It's truly a masterclass for every nurse to apply with every patient. Link is in the description. I can't wait to see you there. Yeah. Well, and speaking of the criminal justice system, it's like, I think it's easy to hear about or somebody disclose to you that they have experienced sexual assault in whatever format. And the natural thing that we say is, well, did you report it? And why not? You should report it. You know, even for myself, I wasn't really planning on talking about myself, but it's hard not to because I have lots to say about this personally, and someday I will. But even myself, like one of the number one things that I hear if I'm ever going to share with someone about what happened is like, well, did you go to the police? And I did not. And that was a conscious choice. And the amount of not getting it, or, well, but you should, and well, can't you now? And I understand that it comes from a place of like wanting justice, and it's hard to hear, and you want to fix it, and you think that the criminal justice system will fix it. But the reality is what? Like, even people who do report, how often does that actually amount to a conviction?
So that is a difficult number to pull out, and here's why. Okay. The reality is, nationally, we say fewer than 10% of reported rates actually result in a felony conviction. So, like, that's kind of,
Hmm.
Um, they
Which
can
means that
plead.
90% of rapists are still walking these streets.
Yes. Yes. But
Yikes.
but the reason I put a tiny pin in that is they can plead to lesser charges. They can make a deal.
Hmm.
So rape is a pretty big felony. And prison culture, things like that, do not take kind to rapists. So, which is good. They shouldn't be kind to rapists. But that being said, being able to, if you're in a situation where it's he says, she said, right? Because we always hear about that situation where it's someone's word against the other, right? We'll use the example of I consented to this, I didn't consent to that, right? That's
Hmm.
still rape. Like she did not consent to unprotected sex. You
Yeah.
decided to take that. That is rape. So there's DNA there. So the forensic kit, like there's she consented to having sex. I'm going to get his DNA. We know this,
Hmm.
right? That is a very hard case to prove.
Yeah.
So they might make some type of negotiation to a lesser charge, maybe a misdemeanor or something like that, which is why those numbers I think that's why those numbers are so low,
Yeah.
but I think that's because I don't want to say we don't have the right laws. I think we haven't figured out how to address this appropriately to get justice the way it should be served. And that is part of the problem, right? So they might only spend 3 years in jail on like a battery charge, like,
Yep.
or something else, or they might not get jail time at all, or
Yeah.
um, they'll negotiate to get off of the sex offender list or so that affects those numbers.
Hmm.
That affects that statistic
Yeah.
pretty heavily.
And when someone is choosing to report to the police, what does that mean for their future of what they're agreeing potentially to for the criminal justice process?
It means you don't get to move on with your life, is what it means. I say that because I don't know what other states look like. I'm really speaking from the lens of my practice. It can take years before they go to trial. And then, so imagine this awful thing has happened to you, and 2 years of your life pass. You're growing, you're moving, you're trying to live your life and move on, do better things. And now you have to go back and be questioned by most likely a not very nice defense attorney, because I mean their job is to make you look bad, make a mockery of you, and
Hmm.
the person has a right to confront their accuser. So you're accusing someone. Trials can be long, they can be grueling, you can be stuck on the stand for a long time, and then there's still no guarantee you're going to get justice at the end.
Hmm.
You might go through all of that and then they get let go, or I've seen it go where like we get all the way down to the last witness and then they take a plea deal, and so you just sat there being tortured that whole time. The other thing too for our I don't want to say victim anymore. I'm going to try to say survivor,
Yeah.
because you know what, you're not a victim here. You're not, and the other women are not. You survived something. You survived something awful that you shouldn't have had to experience. But our other survivors, when you get into that courtroom, when they make those plea deals, you don't really have a say in it. Sometimes the DA will ask you your thoughts or this or that. But I mean, the reality is all of that is kind of out of your hands. So you're
Hmm.
this pawn, so to speak, in a chess
Yep.
game that is the legal system. And they're going to emotionally use and abuse you to make their
Yep.
case, hopefully to put this person off the streets, hopefully to make the world a safer place. Like that is the goal. I
Yeah.
really don't feel like the DA is doing anything like to purposely harm our survivors.
Totally.
But,
Totally.
when you get up there and your emotions and the things are on display, and that defense
To a
attorney
bunch of
is,
strangers sitting there
yeah,
ready to judge you.
imagine when I have to get up there and I might have a picture of your vulva. Like if there was a tear, if there was damage, now your vulva is on display.
No.
Yes, ma'am. So imagine now they will not
Oh
put
my
it on the
God.
projector for the whole gallery. There's usually a screen at the attorneys and then the jury and the judge. But all those people in the jury, yeah. So
Oh,
when you're having a
oh,
baby, right? Those women get used to it. They're like, oh, everybody has seen it, because they had a baby.
sure.
The women and men, anybody, because for men, their penis gets put on display, right?
Yep.
One of the hardest, oh my gosh, this person lives in my brain forever. Um, he came in and he had been raped. He had met someone on Grinder. And when we started doing the exam and started doing the things, and that please understand when I was doing this kit, we have made changes to things. At the time, I didn't ask sex assigned at birth or pronouns.
Mm.
We have
Mm-hmm.
since changed that.
Yeah.
Um, I felt ridiculous when we got to that portion of the exam and he didn't have a penis.
Mm.
And like we got, well, like they were giving me their story and all the things, and they were talking about anal rape and things, and it made sense. And then when we got to that portion, and I was like, this is a trans man.
Mm-hmm.
And I had to shift a little bit and cover them back up for
Mm-hmm.
dignity and then ask some more questions.
Mm-hmm.
And since then, we've made
Mm.
changes to our forms and things.
Yeah.
But I learned a lesson that day because I needed to be better about the care that I gave. Because I assumed he presented as a man, answered all the questions as a man, the
Mm-hmm.
assault and all the things. Um, but I learned that day the effects of testosterone and transition and what happens to a vaginal rape. And it was, could you, and that person eventually ended up saying they didn't want to report because their vulva would have been on display as a man.
Mm. Mm.
And emotionally, they just could not. And I understood entirely.
Yep. Yep.
But imagine that for those people, right? For the people that experience this, and something that is definitely deeply intimate, and more so because now there's a whole other mental health layer added to that, and then to have that be on display.
Yes.
Yeah.
Well, no wonder people don't do rape kits.
Yes.
And mind you, most people, I would say that if they go in to have a kit done, that they're not fully aware of what this could mean
Oh,
in the
they have no
future.
idea. Yeah.
um, but I think going back to what I originally said of like when somebody talks about their experience, that it's like unless you have been there, and even if you have, we've got to really do better at just taking in what is being told with compassion and curiosity and care and really non-judgment. We talked about that in the last episode, but especially in these circumstances, that the question, I will say even for myself, the question of like, well, did you do a rape kit? And almost like in some way that proves that you were raped, is just not helpful. And those that do, I'm thinking about that. I'm like, how brave. And there's a part of me that even is like, no, I wasn't about to like go tell the whole world and do the whole thing. And I know what's a part of a is it a SANE exam? Is
I
that what it's called?
Yeah, a sexual
Yeah.
assault exam, because it's
Yeah.
it's more than just the kit. The kit's a tiny part to it. So it's
Mm-hmm.
a full like forensic exam. So we as nurses, we can start if we're trying to engage in that conversation. If someone is telling you that they experienced an assault, that you, instead of saying, well, did you get a rape kit? You can ask, you know, oh, were you reporting or did you report? And if they say no, you can go, I understand. I understand how incredibly difficult that would have been. Okay. And if they say yes, you know, then you can go down that road of, is it still going on? Is there any way I can emotionally support you? Is there anything I can do for you? Or, oh no, it's all done. Everything's sealed. and be like, wow, you are so incredibly brave. And if you ever want to share, I would love to hear about your experience. So it leaves the power in their hands. It's not shaming them in any way. And it definitely brings to light, wow, you are an incredibly brave person. And I understand and support both of those decisions because it's a hard decision.
Yeah.
Um, Rape kits are very traumatic on their own.
Mm-hmm. Mm-hmm.
Yeah.
I think that that response is like literally the easiest, most simple practice change that we all can make, whether you're in it as a nurse or just as a friend or whatever, of
Oh,
just like that's the response in general, and leaving it open, and again, everything's about control, right? So giving control back
yes.
where it is due. So if someone were to go through a sexual assault exam,
Mhm.
what is involved in that process for you from like a nursing standpoint?
So at our center, we get patients through different avenues. Okay. So I'm going to talk about a patient that's coming into the sexual assault center versus doing something like in the ER or anything like that. Okay.
Sure. Hmm.
So there's, like I said, there's different avenues on how we get patients through either law enforcement. We have a hotline, different things. But once they've made like, hey, I want to come in. This is what I want to do. And we're like, okay. And before they come in, I try to have some conversation, not so much about what happened to them, but set some expectations of like, this is what's about to happen. But they'll come in, and I want to say thank you to all the advocates in the world because I cannot do my job without an advocate. Okay. You guys are very, very important. And because I think when I went into sexual assault nursing, I really thought that I was going to be doing that same emotional support like I do in labor. It is very different. It is very, very
Mm,
different. And this is not the same type of nursing role because I thought I was going to be doing that hands on, like emotional, like all the things. That's
yeah.
really the advocates. Okay. Now I still connect with the patient. But I
Yeah.
only see them this really small window to collect evidence. And I almost need to keep a little bit of separation just because I'm going to be testifying to that evidence. And I don't want an emotional connection or anything like that to cloud any of that judgment or any of
Yeah.
the objectiveness of my data. So, of the
Interesting.
evidence.
So
Yeah.
that is what you're signing up for, is testifying,
Yes.
because now you
Yes.
become a witness to the crime.
Yes, because you are now a cog in the wheel, okay? And we do reporting and non-reporting kits. So when you come in, we're going to sit down and I'm going to first establish, are you medically safe? Okay? Are we in a hypertensive crisis? Are we having a mental health crisis? What's your blood pressure? What's going on? Like, are we medically safe and sound?
Sure.
Are you bleeding?
Yeah.
Is
Yeah.
something bleeding? Do we need stitches? Like, how bad is it? So
Yep.
first off, your medical safety is always first and foremost. And there are times that we have to transfer to the hospital because like this is big enough that I can't do my exam and then
Mm-hmm.
send you. Like you got to go now. If the person is now they might have some injury, but if we are medically stable and like mentally we're good, we're sober, all the things, and sobriety is a big part of this because you have to be able to consent to the exam. Okay. So if
Mm.
somebody gave you something, we need to wait until that's out of your system enough so you can consent to the exam. Or let's say you were consensually drinking at the bar and something happened. You need to
Yeah.
be sober for us to do this. And that's a big piece.
Mm.
So I'll talk about your medical history with you. This is all covered in the medical part of your chart, and I'm bound by HIPAA with that. Okay. And we at our center, we fight tooth and nail to make sure that that doesn't go into court. But I do need to ask some medical questions, right? I need to know if you're pregnant. I need to know, did you have surgery recently? Did you have a baby recently? So all
Yeah.
of that goes in the medical side. On the forensic side, the first thing I'm going to do is I'm going to go talk really slow so I don't have to stop you every few minutes. And do me a favor, try not to use words like eggplant. Say penis. Where did he touch you? Say, if you tell me, oh, you touched my peach, I'm like, I have to stop you and go, nurse clarified, peach means patient's butt. or bottom, or, and I tell the
Mhm.
patients that before they start,
Is it
because
recorded?
we don't record hours,
Okay.
because we don't, that it could be used against you in the wrong
Yeah.
way, and there's
Yeah.
more tone.
Sure.
But so that I don't have to
Okay.
stop you, because we are going to go to court with it. So I can't get on the stand and say, patient, I'm exempt from hearsay. Patient told me that the suspect put his eggplant in her peach. That means nothing in court. So I have to clarify, if they use any kind of terms, if they use anything. So I try to let them know before they start. I'm going to type everything in their words. And I skipped typing class in nursing school. So I'm like, I'm typing like mad woman, trying to get everything in their own words. Your words are important. Your words are powerful.
Yeah.
But we do type them versus recording them. I did have a patient once. She had been held hostage for a couple days, and she audio recorded her rape, and she couldn't talk about it. And she asked me if I could just listen to it and make notes. And so she started playing it. And I said, no, I'm sorry,
Oh,
I
wow.
can't. But I let it play for like 30 seconds, just long enough to have some idea of what was going on and what I was dealing with. And when I was like, okay, I'm so sorry. Like, if now is not the time to talk about this, let's make sure that you're medically safe, because it was the most horrific thing I had ever heard. Um,
Mhm.
but so my exam after that is going to be heavily catered to what you tell me. Okay. Every place that he touched you, licked you, kissed you, hit you, burned you, all the things. I'm making a mental list. And if it's going to be a long list, I will get out a separate sheet of paper and I will start making all the places that I'm going to swab for DNA.
Mm.
Okay. All the places that you know, if you have, for example, a bruise on your neck, right? How do I know the difference between a bruise and a hickey? Well, a suction injury is what we call it.
Okay.
I'm going to swab it. And when the kit goes, if it comes back positive for amylase, for saliva, then it's a hickey. If it
Interesting.
comes back and there's no saliva, then it's trauma, it's a bruise. It's,
Mhm.
you know, so these
Huh.
are things that if you tell me, like, and he bit down and sucked on my neck, I'm proving the steps of your story. I'm moving through with you. The other thing that nurses forget, pain scale, so important. So important. Get a number pain scale. I cannot show your pain. We do like a pain inventory. Tell me, I do a full body scan with my patients. I'm like, all right, we're going to start at your head. During the course of the events, did anything on your head hurt? What about your shoulders? Anything on your back? Everything that hurt, that is trauma and things that this person needs to be held accountable for, that I can't necessarily take a picture of and show.
Sure.
It can be rough, it can be long, 3 hours or more, depends on how beat up they are.
Yeah.
If the patient gets emotional, we take a deep breath, we take a break, right? We take a moment.
Yeah.
So a lot of it too is, where is my patient at emotionally? How much can she handle, or him, they? But after we go through, the longest part is the paperwork part, the story part. I mean, it gets deep. I'm asking now, I do listen. So like, if you already told me he pulled your hair, I'm not gonna ask that again. But after they give me the story, I'm gonna ask, like, okay, did he put anything over your nose or mouth? Could you not breathe? Did he put anything, his hands around your neck? Did he
Mhm.
burn you, bite you? Did he take any of your stuff? Did he take a trophy? Was any of your clothing ripped? Is anything missing? These are the checklist things, right? That unless you do this, you wouldn't think to ask somebody if, and it could be something little like, oh yeah, my keychain, like he took my underwear, or he took, my underwear is missing. I don't know, or this is missing,
Mm.
right? Unless you worked in the space, you wouldn't think to ask if he took a
Sure.
trophy. These are things um, that you learn doing this job. So after we go through all the talking, it is daunting for them. Then we get into the photography and the physical exam. if my patients consented to photography, I never want to push them into anything, but it is definitely a hard one, especially when you tell them you're gonna or you want to ask to take pictures of their vulva.
Yeah.
We have very cool cameras, and I can take a picture of a cervix so good that I can see your IUD strings. Oh yeah.
What?
Oh yeah. We have amazing care. Oh yeah, because if there's trauma, if there's bruising, if there's
Sure.
damage, if there's petechiae, like if there's something going on inside, that happened to you. I'm documenting it. And yeah. So yeah,
Wow.
so after you've gone through a sexual assault, unfortunately, you we offer a speculum exam. Yeah. So, that is very difficult for a lot of women. And I'm going to do a head to toe. I'm going to look at you and then that list of places, depending on what you've told me. I take a buccal swab or buccal, depending on what part of the United States you're from, to get your DNA, right? Because as I'm swabbing you, I'm going to pick up your DNA too. So we needed your DNA for sure. I know that this is my patient, and we put that in there. And then all the other places that I swab, they're looking for something that's not yours. And again, that list depends on what you've told me, like what happened.
Hmm.
Then there's the speculum exam, that's usually one of the last things, but it's one of the harder pieces to do. If I have a male patient and I need to examine the anus, and for my women too, um, so men think that they're never going to get into the stirrups, and we call them foot pedals because that is a less traumatic
Mm.
verbiage. So the foot pedals will put men in the stirrups. You don't ever ask a man to lean over a table or a woman to do an anogenital exam, right? Because think about how traumatic it would be if that's how
Yes.
they were assaulted. So this is trauma informed care. It's moving at their pace. After that part of the exam, after the speculum exam, a lot of times I try to keep them as covered as possible. The advocate is with them the whole time, holding their hands. The advocate's really the one building that emotional bond. Holding hands, we have fidget toys for them, we have things, talking about different things, just anything that we can to help get them through this part. And then you have to read the patient. Sometimes they want to jump off the table and like run to the bathroom and hide, and that's normal. That's totally normal. And if that's what they need, I make space for that. Okay. But sometimes they need a minute, and I cover them up, I sit them up, we get them like reestablished, and I will lower the bed all the way down and get both of their feet on the floor because our gynecological table will go really low.
Mm.
Instead of pulling the table out, because everybody knows that little extra foot table, right?
Yeah.
No, I lower it all the way down so that when they're sitting, their feet are on the floor to ground them. I ground my patient, and we take a couple deep breaths, and I let them know, okay, this part of the exam is done. You
Mm.
did it. That was incredibly brave of you. And, I am so proud of you for finding that little bit of courage to be able to do this with me. And thank you for letting me be here to take care of you. Yeah, I always want to thank my patients for
Mm.
allowing me to be here to take care of them. Um, and then when they're ready, they get to, so we have a full shower, full bathroom, all the things. Cause if they
Oh.
come in and they were in the clothes they were assaulted in and they let me take their clothes, they don't get those back. So we
Yep.
have clothes to give them. I have underwear to give them. I have whatever they need. And thank you to all of our community resources and donations and things that make this possible for our center to do this, because without you, we would be lost. Okay. So, I mean, think about how many single serve toothbrushes and mini
Yeah.
deodorants and feminine care supplies, because sometimes they're on their period, and
Yeah.
all of these things. So, we have a full shower, full towel service, all the things for them. They can go shower because
Amazing.
ideally we would get a hold of them before they shower or anything when they've got all the DNA and all the grossness on them. That's what I want. Right.
Hmm.
So now she's just gone who knows how many hours without self care, without feeling clean. So they can take advantage of those services if they would like. And then after that, we'll talk about medications for STI prophylaxis if that's something that they would like. We do offer Plan B or a Plan B, like alternative, but we do have that to if we're worried about pregnancy. And then after that, I don't get to see them anymore. They stay with the advocate. That is the
Hmm.
end of my journey with them. So I will dry and package their kit and it will get picked up by police and it goes off for me. It goes to the GBI, so my state crime lab. If they are a non reporting kit, so if they came in and they are not filing, then they will never know what's in their kit. It will never be tested. Non-reporting sexual assault kits stay, we have to keep them for a year. Now I will say that our center has some from well over a year, so if something were to ever pop up, we could go back pretty far, but we are required to keep them in storage for a year in case they decide to report.
Yeah.
But they will never know, they will never get answers if they don't report.
Huh.
Yeah,
Is
there's
that
just not.
why there's like millions of rape kits sitting somewhere untested? Is that
That's
where that
probably.
stat comes from?
So where that I believe comes from, and I don't know the true origin. There was a time in Georgia where there were tons and tons and tons of rape kits from reporting kits that weren't getting tested. We did not have the capacity or the money.
Mm.
And yeah, the district attorney of New York sent money and they started testing all these old kits. So we're talking kits that were over 10 years old. So all of a sudden people had like moved on with their life and they're like knocking on the door, like, hey, by the way, we tested your kit and blah, blah, blah. So that's where all that came from. And now we have a mandatory tracking system and there are hard limits. It has to get picked up in a certain window of time. It has to be sent to the GBI in a certain amount of time. Now, once it's there, it does have to get tested. But how it moves through the court system, there is a little bit of backlog, which is why it can take a while for things to get tested and go to trial. But it's not 10 years on testing anymore. But because of the overwhelming number of reporting cases, a non reporting case does sit untested because they have to
Hmm.
prioritize the resources
Sure.
for those cases that are being tried.
How much does doing a rape kit actually help your case?
Sometimes it can be what make or breaks things, right? Like it really can. I think it depends on the case, right? But then there's also these moments of, well, why wasn't there any DNA there? Well, I didn't swab in the exact spot, that he, like, especially if they use a condom or this or that. Like, there's so many explanations. Like, she had already showered. It was 3 days out. We tried, but it happens. The
Hmm.
vagina, in and of itself, wants to be clean. Someone else's DNA and cells on us is foreign matter. Our body's going to instantly start working to get rid of it, right? Like,
Yep.
our body doesn't want that there. So call in to question things, but the rape kit, the swabs themselves are a small piece. What I do as a nurse is your story, your pain, your physical injuries, the photos, that is so much more than the swabs of the rape kit. I am I am so much more for you as an advocate in the courtroom because I can truly convey to the jury the pain that was in your eyes, the distress, the like you came to me wanting help and you can tell, you can see it. As nurses, we are trained to do a head to toe and part of that is assessing someone's mental status, right?
Hmm.
Are they alert and oriented? Are they withdrawn? Are they, and I write a note to that, like what is your demeanor? Some people are very like hyperactive. This is their response. Like, and these are all normal responses, right? And we talk about that, when we get to trial, right? These are normal responses, you know? And I'm there, like, this person probably wouldn't have been behaving in this manner had they not experienced something traumatic.
I would love to know from you how your work as a forensic nurse informs your practice as a labor and delivery nurse.
My entire practice changed when I learned this. Trauma informed care and maximum self determination, right? Like
Mm.
how I approach my patient, I almost stand guard, not in a bad way. Like I don't want to be the problem, but in if I know that my provider, for example, wants to come and check their cervix and whether they have disclosed or not, right? I just take the stance that every woman has experienced something unwanted at some point in her life,
Yep.
whether she's disclosing or not.
That's fair.
And I will, if they're like, let's say the provider's like putting on the one glove and you see them start to reach for the covers, I'll kind of put my hand on the cover. So like they can't just jerk the cover back and say, is it okay if we go ahead and uncover you? I
Yep.
started uncovering bottom to top, never top down, never.
Mm-hmm. Yep.
I like change that and I stop my providers when they go the other direction. You don't do that in the office. Don't do it in labor and delivery. Give her some dignity, keep her covered.
Yep.
Now I understand when we're having a baby, it's got to come off. Okay.
Sure.
But if given the situation, I can keep a sheet over them. If that's what's appropriate in the moment, that's what I do. I am purposeful. I explain everything differently. I purposely stop checking the boxes on the computer with some of those questions because don't get me wrong, I'm still in the hospital with you and I'm having to make the man happy and check all the boxes. But there's definitely certain questions that I stop and I sit down or I stop and I turn and I make sure that my patient sees my face, sees that I'm genuinely here and I'm genuinely asking not to check a box.
Which ones?
Okay. I mean, all the intimate partner violence ones. Tell me when I do their obstetric history, I turn and like look at them because when you talk about a fetal loss or anything like that, like until I know that this is a first baby, like I am 100% engaged and offering trauma informed care because I have no idea what she's about to tell me about her obstetric history. The intimate partner violence ones. I also will ask, if there's anything that I can do to make their stay or their time during labor and delivery more comfortable. And even though it's not the check boxes, I do ask if there are any cultural things that I can do for them while they're here. Different communities, you have different, and you get to know some of the like pocket religious communities around you. We have a very large Jewish and Muslim population around here, like Orthodox Jewish, and I had to learn their traditions and their things to understand and not be judgmental, but also to offer comprehensive care.
Yep.
Um, Again, if they say I don't want any men to do the cervical checks or no men in the room, right? If I don't obviously know that it's a religious thing, like if it's,
Mm-hmm.
oh, it's for my religion or oh, it's for this, that is another segue for me to ask. I totally understand. We will, I do my best to accommodate whatever that is, but I will probe and ask why
So
in a
how would
nice
you
way.
say that? How would you say that?
If it's, I don't want any male healthcare providers, sometimes I can make that happen, sometimes I can't. And I
Sure.
educate to that effect, right? If it's something that I can't, then we talk about what we can do. And then I'll ask, okay, if you don't want a male healthcare provider, may I ask why? I don't want him touching my vagina, this and that. Totally understand. And again, we've established it's not a religious thing. I'll go, did something happen? Is there a
Mm.
reason? Is there something you would like to share with me? And yeah, I go pretty direct with it, but in a sitting down, if it's appropriate, you read your patient either on the side of their bed, like some of the providers will when they're checking them, or in a chair. And sometimes you'll see tears form, you'll see this and that. Read your patient, know your boundaries, but sometimes it's appropriate to reach out and touch their hand, sometimes it's not. Just know, like, they're asking that for a reason, and that trauma informed care. I've had more patients from the point that I became so the labor and delivery journey before SANE, I felt like nobody ever disclosed, like everybody was fine. Once I started doing this trauma informed care, the connections that I made with my patients and the number of women that disclosed anything, it's astronomical. It changed how I connected with my patients, but also it's a healing journey for them to go through labor and delivery with someone that is on their side, someone who understands, someone who can be there and support them. If I know that that check, even if it's going to be a female that's checking them, is going to be traumatic, would you like to hold my hand? Let's hold my hand. visual guidance, like, where do you want to go? Are you a beach or a mountain girly? Where are we going? Let's go together. So you have
Mm.
no idea how many like mental journeys I've taken with women during those cervical checks because they're not alone. I'll go with them. Are we standing there on the beach looking at waves while we're contracting? I stand there right with them.
One of my stances and one of the phrases I use is we don't need to know why, but I'm sure they have a good reason for whatever the response is, like whether it be related to a cervical check or not, or something else. And so I'm curious to you how, when someone discloses to you that they have a
Mhm,
history,
mhm.
what changes for you in your care of them, and how does that disclosure actually impact the rest of their labor, your shift, etc.?
I do put it in their chart. So I will chart it in their history. I because I'm a forensic nurse also, I will establish, are we safe now? Is it our current partner? Like I will ask those probing questions that I am trained to ask, and
Mm-hmm.
because of that. Because again, safety first.
Yep.
Is it the person that's in the
That's
room? Is
fair.
it what, like,
Yeah.
safety
Yeah.
first. Then once I've established like we're safe and we're good, chart what I need to chart. The next thing is the healthcare team is made aware. Okay. The healthcare team needs to know that the way you approach this patient, you need to pause at the door. You need to pause at the door. You cannot come in here because if you're like hyped up and amped up, she's going to get more amped up. We're going to ruin the hormones.
Yep.
This is a very specific physiological process we have to go through, and we need to preserve that mental space for her. So
Mm-hmm.
we are mindful. We do not say open our legs. And I have definitely looked at some residents and been like, hey, this person has experienced sexual assault. I want you to be mindful of your words. Do not tell her to open her legs. If she is having trouble relaxing, do not tell her to put her bottom down or relax. Say, hey, okay, this seems like to be a lot. Do we need to take a moment? Is there
Mm-hmm.
something I can do to help you through this process?
Yep.
Okay, we are not going to use the same language and the same things that they probably heard from their rapist while you have your hand inside of them. Okay. And I will, so I am very,
Yeah.
very mindful of that when I'm aware. And that's the one thing that kills me is open your legs. Like, oh my God,
Mm.
please don't ever say that.
What other things should nurses never say?
Telling people to relax, it'll be okay. It's almost over. Like, just, you don't know. So, instead use empowering things like, let's take a deep breath. You are doing amazing. The baby is almost here, right? Instead of it's almost over, or, stop screaming, or, I understand we want them to relax, but instead of saying, just relax, like, because that works here, be happy, that
Right.
works. What can I do to help you relieve the tension in your legs and pelvis? Let's
Mm.
take a deep
That's a
breath,
good one.
right? Bring your feet together, and then I want you to take a deep breath and release like a butterfly. Allow your knees to butterfly out. The other thing that we'll do is with the backs of your hands, because the backs of your hands are safe, you can hold your hands out wide and say, when you're ready, bring your knees to meet the backs of my hands. And that would then have them open their legs to meet you.
Oh,
And
that's
because
such a good
remember,
one.
touching happens with the insides of our palms, the back sides of our palms. That's safe touch. That's good touch, right? And we say that, hey, this is me. And when you touch your patient, remind them, hey, this is me. I'm touching you here. This is my touch. And start with the backs of your hands.
Oh,
Start with the backs of your hands and go, hey, okay. And like, if you need to, walk in their thighs purposefully, not ridiculously slowly, but you'll see some providers do the thigh walk.
yeah.
But some of them will be like, touch, touch. Now I'm like inside of you. And I'm like, that is not how that's supposed to go. But,
Yeah.
it's supposed to be purposeful, safe touch. Okay. Hey, this is my touch. I'm right, at the apex of your thighs. Are you ready for the cervical check, the exam? And then the patient can go, yes, okay, I'm ready. And then you get, all right, this is my hand. You're feeling my touch. And then you check the cervix. And it's allowing them to be used to the touch, right? Sensory overload,
Yeah.
right? And it reminds them you are here, you are safe. This is my touch. It's not someone else's touch. You're not reliving something. This is me and my touch here with you. And
Mm-hmm.
reminding every patient, because especially those, when I see my patient lay their head back and close their eyes, those are the ones I get scared with, because I
Mm-hmm.
don't know where she's going in there.
Yep. That's such a
She
good
could
point.
be, she could be going anywhere in there. It could be a positive place, right? And as long as it
Yeah.
stays positive, and that's fine. But if she goes in there and it goes somewhere negative, she just went by herself.
Is it just cervical checks, or are there other instances in labor that we need to be especially aware of?
I mean, it's everything, think about the control aspect, right? It's a loss of control. It's a loss of bodily autonomy when it comes to rape and assault and unwanted touch. It's the same. We already talk about these things. Like, women feel out of control. Yeah. Team underwear. Do you want your
Mm-hmm.
underwear? What do you need to feel safe?
Yep.
And I understand it might be inconvenient. And women ask, do I have to wear your gown? You can wear whatever you want as long as you're okay with me cutting it off in an emergency. I will do my best to remove your beautiful labor gown, and just know it's going to get messy. But yeah, wear whatever you want. You know,
Mm-hmm.
can I keep my underwear? Absolutely. Just know that we may ask, or if this baby is imminently coming, can I cut it off? you know,
Yeah.
and as long as you're okay with all of these things, I am down with that. Breasts, while they are there to feed the baby, they can be sources of trauma. So many different things, how we expose our patients. I say this because when we go to do skin to skin, if mom says, yes, I want to do skin to skin, and then as nurses, we're like ripping the gowns off and trying to shove the baby in, and I'm like, whoa, hey,
Yep.
and I get it. We have a wet baby. We're trying to warm the baby. We're trying to do so many different things. But I'm like, whoa, slow it down, Tonto. Like, hey, you would like to do skin to skin. May I go ahead and uncover your breasts and let's put the baby on? Okay, yeah. Because I know when we say skin to skin for us, it means I'm going to lay this baby on your bare chest.
Yeah.
But that might mean something different to someone else. Like, making sure that they understand in that moment, like, what does it mean? Or, because as soon as you start tugging at their clothes, that can be traumatic for them. Someone
Totally.
pulling at your clothes. Yeah.
Yep. Yep.
And I
So true.
understand we have emergencies, and we have things that happen that, like, we act quickly. This is why debrief for nurses as well as patients is so, so important, because, I understand we might have had to cut whatever that gown off, do this, do that. We were in an emergency. It happens. I'm sorry that that took place. Do you want to talk about it?
Mm-hmm.
Is there anything I can help you better understand?
Yep.
Because that's how we're going to prevent the next problem.
There's so much more that we could go into. And again, like,
Mm-hmm.
we can bring you back. And so if you have questions for Morgan, if you have follow ups, please email us. We see every email that comes in. You can email nurses@bundlebirth.com, and I will start a running list of those questions. And then maybe next season, if there's a list of questions, or if just like other conversations come up, we will have you back, because I think this is one of those things that, like, we don't actually talk about, but we imply so
Mm-hmm.
much, and we know is happening. And yet for me, it's not taboo whatsoever. I'm like, let's go there. Let's have the conversation. But it's harder to talk about, and it is slightly taboo, and there's lots of layers involved and all of that. So that being said, you work with people and end up in these scenarios where you are with them on potentially one of the worst days of their lives. What have survivors taught you about healing or life that most people maybe don't understand?
There's always another day. I learn from those things, but I don't look back. Those things are the foundations of who I am, and I'm not going to feel shame in them. Survivors have taught me not to feel shame. It might not be the thing that you want on the billboard. It might not be the thing that you want to talk about, or want everyone to know about, but I will not be ashamed of the things that have made me who I am. But my life forward, I I look forward to tomorrow, and what is the next thing, and I can go into it with tears, or I can go into it with a deep breath saying, today is a new day, And if I can do that and survive that, I can handle whatever else is coming my way. The other thing that I learned from survivors and in this community, and I have to tell myself often, is I'm not alone.
Mm.
And going through this and working with these people, you are not alone. There are communities like Bundle Birth, like, just move in and of itself, just expanded my universe. And at any point, you can be out there and there's someone going through those same things, those same feelings, and you are not alone. And it's like when I mentioned in one of the previous podcasts when I had a student who was a patient and I said, "How are you?" And she's like, "One day at a time, and I'm going to do something better today." She's in nursing school.
Mhm.
She's in the beginning, like the very beginning. And
Mhm.
I'm like, this is amazing. This young
Yeah.
woman is coming out of the darkness and stepping into the light and is not going to let that stop her from shining.
Mm.
She's not going to let her stop that from living. And that's what we do.
Mhm.
So sometimes people are still in the dark. So when they come to me at the SANE Center, they're still in the dark. But I'm like the little light that's like, come this way, step back into the light with me. It's okay.
Thank you once again. I've said that at the end of every episode, but especially now, I just feel like so grateful that you would be willing to share your experience and your knowledge and your expertise in all of that with this community. If you want more from us, head to bundledbirthnurses.com, subscribe to our newsletter, follow us on Instagram. And also, I have dropped a link down below. If you want more related to this particular topic from the last 3 episodes, just drop your name and email and we'll keep you on a list and keep you updated as we continue to have these conversations. Because I think, while this might be the first, I hope it's not, but for many of us, it will be the first time we've heard these types of conversations addressed. And it's not the end. And if we are going to be top of our practice, excellent, full scope, game changing nurses, we've got to have the courage to have these conversations and push into the darker places so that we can also be the light.
This is the time where you take everything that you've learned today and you be the light in the labor room.
We'll see you next time.